go. All right. Good evening. My name is Christian Follier. I'm the director of the Acute Surgical Pain Management Fellowship at the Middle Tennessee School of Anesthesia. I'd like to welcome you to tonight's Ultrasound and Pain Management webinar.
And my name is Nicolette Hogue. I'm the Executive Director of Postgraduate Education. Welcome. Thank you all for joining us tonight.
Tonight, we're joined by two special guests, Dr. Mark Gavitt and Dr. Jeremy Heiner from the Kaiser Permanente School of Nurse Anesthesia. And tonight, we'll be discussing point-of-care ultrasound to assess the cricothyroid membrane and some strategies to assess the cricothyroid membrane in a can't intubate and can't ventilate situation. So at this time, I'd like to turn the presentation over to Dr. Gavitt and Dr. Heiner, who will start with a brief discussion regarding point-of-care ultrasound.
Great. All right. Well, thank you both Dr. Hogue and Dr. Follier for inviting us to be on this webinar. We've really been, both Mark and I have really been looking forward to participating in this and talking about what we love to talk about, which is airway and point-of-care ultrasound. So I'm going to go ahead and get going and share my screen. And we're going to start by talking about some airway. You can see the objectives here. And as I mentioned, we'll talk about some POCUS. And really, we're going to focus on access for an emergency airway. So we're going to talk about cricothyrotomy today. Now, everybody knows when they go through anesthesia school, and certainly during their clinical training and then afterwards, that this is what we prepare for, the difficult and failed airway. Because we know that we're considered the airway experts in the hospital, and rightly so, because we spend so much time managing the airway during surgery and on rapid response teams as airway providers. So this is what we want to prepare for, the rare can't intubate and subsequently cannot ventilate scenario. So this is certainly a significant cause for anesthesia-related morbidity and mortality. You look at any closed claims analysis, and you will see that the primary problem with responding to this potential this emergency is a delay in doing a cricothyrotomy. Cricothyrotomy, it is the final step. No matter what airway algorithm you look at, whether it's the ASA difficult airway algorithm, whether it's the difficult airway society, difficult airway algorithm, look at any emergency checklist, look at the Stanford emergency manual, look at any other checklist, and you'll see that if you cannot intubate, and then most importantly, if you can't ventilate with a mask, or if you put a supraglottic airway in and are having difficulty or the inability to ventilate with that, you got to go to the neck. And there are several terms for cricothyrotomy. I think cric or cricothyrotomy is probably the most commonly used one, but emergency front of neck access has emerged as a common term, especially in the literature. And I'm going to invite my fellow presenters here today, jump in here and let's talk a little bit about these airway algorithms. Certainly with the new updated 2022 ASA difficult airway algorithm, there is a couple of major changes. Number one, there are questions that really guide the practitioner once they've identified a difficult airway and a difficult ventilation or a high risk for aspiration type of a patient, then it really gears them towards an awake intubation, which we really won't be talking about today. But once we're in that non-ventilatory pathway, that emergency pathway in the algorithm, there is language that says move to a cricothyrotomy and don't delay in that decision. What are you guys' thoughts on the updated airway algorithms?
Well, I mean, personally, I feel like they've done a good job simplifying it. I felt like in the previous algorithm, there were a lot of arrows and a lot of directional. Now, they have pretty much narrowed it down to what you should be doing. I think recognizing early supraglottic oxygenation probably throughout, and again, preparing for cricothyrotomy early in the process.
You know, it's interesting. If you look at the 2025 Difficult Airway Society difficult airway algorithm, they updated that, and there's a major change. So they simplified their algorithm into really 4 steps: a plan A, plan B, plan C, and plan D. Plan A is your original airway plan, whether that's using VL or direct laryngoscopy, and then if you're having trouble, you mask ventilate. If that plan A fails, it says plan B, go to a supraglottic airway. Plan C is if you have time, you can try ventilating one more time or possibly doing a VL one more time. But then plan D is cricothyrotomy. In their updated guidelines, they're saying right after plan A, call for cricothyrotomy equipment. You don't necessarily have to use it, but at least that decision is being made early on.
And Jeremy, just out of curiosity, at your facility, do you have a predetermined or, a cricothyrotomy kit you use? Have you created your own kits with a bougie and a scalpel like we're going to demonstrate tonight? Or is there any guidance in the new difficult airway algorithm as to what we should be using?
Yeah, that's a great question. So if, again, along the same lines as of the Difficult Airway Society, they recommend a surgical cricothyrotomy using the bougie-assisted technique. So a bougie-assisted surgical cricothyrotomy. And the reasoning is because those pieces of equipment, a bougie stylet, a scalpel, a 6-0 endotracheal tube, you can pretty much find in any area of the hospital. If you're in the ER, you can get that. If you're in the ICU, you can get that. If you're having trouble getting a scalpel, open a central line kit. Bougies are available, 6-0 endotracheal tubes are available, and certainly in the OR, we have that equipment. It's easy to get, and people know what they're looking for when you ask for those 3 things. We'll talk a little bit about the needle cricothyrotomy, because I'm sure that there's some participants here on the webinar that are having some questions about the needle cricothyrotomy. We'll talk about that coming up. All right, so before we get into scanning for the cricothyroid membrane, we just wanted to present a little refresher, a little review, maybe a little PTSD on the anatomy of the larynx. And I say PTSD because on my boards, there were so many questions about the larynx. Even in my Mac check now, there are so many questions about the anatomy of the airway, which rightly so, right? We should know our anatomy very well. So the larynx is certainly consists of some important cartilages. The thyroid cartilage, we'll be seeing that today. The cricoid cartilage, we'll be seeing that today. The epiglottis is there as well. And then we have our paired cartilages, our small paired cartilages that are involved in vocal cord function. The larynx is really what's known as the crossroads between food and air. So when we swallow, that epiglottis is saving us, and food slides right over the top of it. We certainly need the larynx as an essential part of our living and breathing. So an adult larynx, if you remember, is right in front of C3 to C6 vertebra. And this is important because usually when we're teaching this concept, and especially when we're teaching this concept to anesthesia students, we typically have that top-down view, which is a 2-dimensional view in the textbooks. And it can be a little misleading in the fact that the start of the epiglottis, the very top of the epiglottis, is several centimeters above the actual vocal cord opening and certainly the cricoid cartilage. So you can see the functions here: airway protection, ventilation, phonation. We know that is an essential part of the larynx. Does anybody have anything to add about this important piece of anatomy? All right, hearing nothing, we're going to move on to what we do to scan the neck. And I'm going to turn it over to my colleague and friend, Dr. Mark Gavitt.
Thank you, Jeremy. And again, thank you for allowing us to present to you guys, Nicolette, as well as Christian. So in terms of assessing the airway, why are we doing this? It's basically for patients that we identify as potential difficult airways, where we have a little bit of time beforehand to go ahead and scan them and identify that cricothyroid membrane, because just as Jeremy said, it's going to be the last step in any algorithm that we're going to be doing in regards to cricothyrotomy. So it's important for us to identify where the cricothyroid membrane is. Now, in most situations, we would be able to palpate it just with our fingertips. But in patients that are going to be anticipated difficult airways, it may be we may be unable to actually palpate it because of obesity. Maybe they have a large, maybe they have some sort of abnormal anatomy where we just can't palpate and identify where the CTM actually would lie. We can use the ultrasound as basically our mind's eye to identify a box that dictates upper, lower, as well as left and right borders of that cricothyroid membrane. So with that being said, I'm going to provide, just some ultrasound assessment pearls in regards to assessing for the actual cricothyroid membrane. So I recommend obviously using a high frequency linear transducer because the high frequency allows you to look at very superficial structures using, again, that high frequency ultrasound beam and whatnot. And this provides, number one, high resolution for looking at those very, very superficial structures. When we look at the transducer orientation, the orientation is very critical, so we know exactly where we are in regards to the airway. So in the transverse view, also known as the short axis view, the indicator that's on the actual transducer should be pointed toward the patient's right side. And that way, us as providers, CRNA, or anyone else in the room has an idea of where we are in terms of orientation. In contrast, when we're doing a sagittal or longitudinal or long view, the indicator should be pointed towards the patient's head. Again, so we all have the same frame of reference in regards to where we are with that transducer in regards to that actual CTM. Another important consideration that we can do or use during ultrasound assessment of the airway is color Doppler. Color Doppler can be used to identify, number one, the vasculature that overlies maybe the CTM, or maybe is just lateral, because the last thing you want to do is, manipulate the airway to the degree of, cricothyrotomy and causing increased bleeding where it's not actually necessary. So we can actually identify any aberrant vessels that's in the area and ideally try to avoid those if you have to go to front of the neck access. So again, major vessels overlying the CTM are very, very rare and are considered aberrant. But if they are there, it gives us the opportunity to ideally avoid them, or just be cognizant that, hey, if we do have to go through it, there's going to be some bleeding that's going to be occurring at the same time too. So Jeremy, can you go to the next slide, please? So the first ultrasound technique we're going to discuss is the TACA, also known as the TACA technique. Now, TACA is an acronym, and it stands for thyroid cartilage, air interface, cricocartilage, and then back up to the air tissue interface. So this procedure, the TACA technique, is performed with the transducer in the transverse orientation. And it's particularly useful when you're trying to identify basically the midline of the airway. Again, this is going to be for patients where you can't palpate and you need the ultrasound as your mind's eye to identify where the actual midline of that trachea is. So the technique works by identifying basically two major landmarks. You're looking for the thyroid cartilage superiorly and then the cricoid cartilage inferiorly. And then once those two structures are identified, we've effectively localized the actual CTM is, because we know that the CTM is between the thyroid and the cricoid cartilages. One of the advantages of the TACA technique is it's very, very simple to do and perform, as we'll see in the next slide. So in a very stressful situation, it provides a quick assessment as well as a reliable assessment to find that midline, thus orienting yourself as well as others in the room so we can all work as a team. Next slide, Jeremy, please. So this slide demonstrates the actual scanning motion for the technique. So you're going to begin by placing the transducer over the anterior neck. Next, you're going to identify the thyroid cartilage first, and then slowly slide the transducer or towards the patient's feet, while again maintaining that midline. As you continue downward, you'll encounter the air interface and then the cricoid cartilages. The arrows that are shown at the bottom of this slide present the actual scanning motion. The key point is to keep the transducer centered and maintain your orientation throughout the scan. Once you've identified both the thyroid and cricoid cartilages, you stop. And then the cricothyroid membrane is located between those two landmarks. So again, you go to thyroid, air tissue interface, to the cricoid, and then back up to the air tissue interface. And that's where you actually stop. Jeremy, can you go to the next slide, please? So now let's take a look at some sonoanatomy. More specifically here, we're going to look at the actual thyroid cartilage. Now, if you look at the ultrasound image on the right, the thyroid appears as an inverted V. Some, texts may call this the shield sign because it almost resembles that of a knight shield. This characteristic shape makes the thyroid cartilage one of the easiest landmarks to remember. So just remember it's sort of V shape. Here we have it as a more of a triangular shape. So we have that V characteristic with it. The anatomical model on the left helps us correlate what we're actually seeing on the ultrasound in relation to the actual patient anatomy. Just for the future slides, as we move through the images, you'll see how these structures change as we scan again from cephalad to caudad, or from the head down to the feet. Next slide, please. So as we move inferiorly or caudally, now we arrive at the cricoid thyroid membrane. This is the air tissue interface, remembered, as I mentioned earlier, in regards to the TACA technique. Here, the cricoid thyroid membrane appears as a bright hyperechoic structure that is between the thyroid cartilage as well as the cricoid cartilage. And this is the target we're really trying to identify, number one, and eventually access if we have to for emergency front of the neck access. When I teach airway ultrasound to students at KP School of Anesthesia, I want to always emphasize that we're not always looking for the perfect textbook image. What we're doing is actually looking at relationships to structures, because again, a lot of these patients that are going to be having difficulty with airways are not going to have straightforward airway anatomy. We're trying to look for relationships between the thyroid, cricoid cartilages, and that tissue in between those two. Next slide, please. As we continue more caudally, now we visualize the actual cricoid cartilage. Now, unlike the thyroid cartilage, the cricoid cartilage appears as a more rounded hypoechoic structure surrounding the airway. Sometimes some people call it horseshoe shaped because of its almost like arch-like appearance. Notice that it's very smooth as opposed to the triangular shape of the thyroid cartilage. The cricoid cartilage serves as that inferior landmark of the cricothyroid membrane. And it's often easier to identify than the actual membrane itself, again, because it's so prominent in regards to actually looking for a definitive structure. So again, we go to thyroid, air tissue interface, cricoid. Now we would slide back cephalad back to the air face, and that brings us to the next slide. And again, this brings us where we originally want to be, which is at the cricothyroid membrane. Again, here we can appreciate the CTM situated between the thyroid cartilage as well as the cricoid cartilage. At this point, we've used the TACA approach to identify the midline as well as localize that actual membrane. So again, the goal of airway ultrasound is to make the process reproducible and reliable. So you can do it with normal patients for practice. That way, when you actually encounter a more challenging airway, you have an idea of what you're dealing with. You can always identify the thyroid cartilage, you can identify the cricoid cartilage, and obviously in between those with the tissue interface, that being the actual CTM. Next slide, please. The second major technique is known as the string of pearls approach. Now, unlike the Taka technique, which uses a transverse short axis view, this technique uses a sagittal or longitudinal or long axis view. Now, the name string of pearls comes from the actual appearance of the tracheal rings, which, funny enough, resemble a string of pearls that are lined up one after another on that chain. For this actual view, we begin by identifying the tracheal rings. Then we slide the actual transducer cephalad the cricoid cartilage. The first large cartilage that we see is going to be that cricoid cartilage, and this marks the superior end of the trachea or the inferior end of the actual CTM. Immediately above or cephalad to the cricoid cartilage is going to be the cricothyroid membrane. One advantage of this technique is that it allows us to directly visualize the superior as well as inferior borders of the membrane. Again, creating a little bit of a bubble. We know exactly where our access point is for that front of the neck access. Next slide, Jeremy, please. So this slide basically demonstrates how the string of pearls technique is performed. We start in the transverse orientation, and then we rotate the probe 90 degrees so that it is now in the longitudinal orientation to again identify those tracheal rings. Once the rings are visualized, we slowly slide the transducer cephalad, and as the tracheal rings transition to the larger cricoid cartilage, you'll be able to identify the CTM just superior to it. Again, the scanning motion shown here is simple. It's also highly effective. And as I mentioned earlier with the Taka technique, we want it to be reproducible between different patients. Next slide, please. So this image on the right demonstrates the sonographic appearance of the string of pearls technique. On the right side, again, are the tracheal rings, which are visible caudally towards the patient's feet. And as we move cephalad, we encounter the larger cricoid cartilage. Between the thyroid and cricoid cartilage, again, is the bright hyperechoic thyroid membrane. And when we use these two techniques, i.e. the Taka technique as well as the string of pearls technique, we're able to establish, again, the lower border or the upper border as well as the lower border of the CTM. And we can accurately and confidently know where we need to access the patient in an emergency situation. With that being said, that emergency situation involves cricothyrotomy, and I'll hand the mic over to Jeremy for that portion.
All right, yeah, thanks a lot, Mark. Because really, this is where the rubber meets the road. And if we're going to be doing this assessment, we want to know where the cricothyroid membrane is. And in the event we get into trouble or we end up in that plan D, which is cricothyrotomy. So here's a little bit of information on maybe some patients where we would want to do this POCUS assessment of the cricothyroid membrane, the larynx, and all the associated anatomy, and then mark that cricothyroid membrane prior to wheeling the patient back into the operating room, or maybe we're pre-oxygenating a patient outside of the operating room, and we're anticipating that there could be some difficulty. Well, we could mark that cricothyroid membrane by performing the POCUS assessment really quickly before we manipulate that airway. So documented difficult airway cases would be an indication, some significant pathologies, and this would be really helpful, especially if there are masses in the neck, because usually when that happens, there's altered anatomy. So knowing beforehand where that membrane is located and using a POCUS assessment can be very, very helpful in these type of pathologies. Certain surgical procedures, especially ENT procedures, and we can use POCUS for an airway exam and potentially mark that as well. So as Mark mentioned, the Taka, the string of pearls together can locate that cricothyroid membrane. And luckily enough tonight, we're both Dr. Hogue and Dr. Fellier, they're going to show us. They're going to demonstrate the technique of POCUS of the cricothyroid membrane and marking that particular membrane. So I'm going to stop sharing here, and we're going to move over to their lab where they're going to be able to show us these POCUS techniques and how we would mark that cricothyroid membrane.
Okay. Thank you, Jeremy. Thank you, Mark. Okay, so before we get started, as Jeremy alluded to, we want to make sure that we are going to position our patient before we mark them, because we want to position them basically in the position that we would do the procedure that's going to provide us the greatest access to the airway. So what I would probably do is slide the pillow up a little bit, which would allow the neck to fall back, which would give me more access to the airway. The next thing I would do is, knowing that I'm going to be doing superficial structures, I'm just going to go ahead and set up my ultrasound system by optimizing the presets. And we will come over here to our musculoskeletal setting to make sure that the internal workings of the transducer will be optimal for the scan that we're doing. The next thing I'm going to do is ensure that my frequency is set well, and I'm at about between 9.5 and 12 megahertz. So I've positioned my patient, I've got the right preset, I have the right transducer. I'm going to apply sufficient gel. And again, typically as a left dominant person, I would probably scan with my right hand, a needle with my left, but I think for the purposes of demonstration, I'm going to scan with my left hand to give you a little better visual. So again, orientation indicator facing the patient will be to the patient's right. What I am going to do is I am going to drop the transducer high in the neck, and I am going to look for a triangular shape image. I'm going to adjust my depth and my gain and optimize my image here. So here you can start to see the triangular structure. I have my focus roughly where I need it. And again, what I'm going to do is scan, make sure my time gain compensation is optimal. So again, here we have a nice triangular structure. Dr. Hoag is young enough that you can see her vocal cords moving, which is great. As we age, that thyroid cartilage tends to calcify and becomes a little more readily apparent. So again, in this TACA method, we're in transverse orientation. The T stands for thyroid cartilage. We are going to start scanning distally, and as we scan distally, we are going to start seeing some air tissue interface. And again, if I put the pointer on, as we scan distally, we now start to notice this air tissue interface. Now, before I just make an assumption that I'm at the cricothyroid membrane, I'm going to continue to scan caudal until I find my cricoid ring. Okay, and here you can see we have a nice C-shaped or horseshoe ring. You can see that cricoid cartilage. So I am going to scan back proximal until I have that air tissue interface. And I'm going to go right about here. I'm going to adjust my depth and my gain a little bit until I get exactly what I want. At this point, what I will do is I will throw on some color Doppler. I think it's always important anytime you insert a needle into the body, you should always stick a little color Doppler on in the needle path. It has been my experience that at times patients will have an aberrant vessel or some sort of vasculature coursing over that cricothyroid membrane where we want to insert the needle. So we want to be cognizant of that. So here, I feel pretty comfortable that I'm at the cricothyroid membrane. Again, if we look at some structures here, I do have a little air artifact. This can be corrected by applying a little extra gel on both ends of the transducer. But looking here, you can see we have our strap muscles in the neck on both sides. These are most likely our sternothyroid, sternohyoid muscles. But most importantly, down the center of our screen, you can see it's just soft tissue. And again, there was no vessels appearing on Doppler, so I feel pretty comfortable that when I insert my needle along this trajectory, I don't have to be too concerned about hitting any aberrant vessels. Okay? The only other thing I would recommend, again, if we rescan this, and again, I'm going to apply a little gel to get rid of some of the artifact, is you can always add a center line to help you identify the center of the transducer. So again, if I start here and I start with my my thyroid cartilage, slide distally. At this point right here, now I know the center point of the transducer. I can line my needle up with the center point of the transducer and be more confident. If we're in a preoperative setting, what I would do is I would take a surgical pen and I would just mark the center line of the transducer so I know where midline is of my cricothyroid membrane. So now that we have found midline, what we will do is we will look for the superior and inferior borders of the cricothyroid membrane using the string of pearls method. So again, I've got the same presets. I'm happy with those. We're going to start again in transverse orientation. Orientation indicator is facing the patient's right. I am going to drop the transducer into the sternal notch. And then again, as I drop it into the sternal notch, recognize that I have a carotid artery. You can see valves in her internal jugular vein. And as I slide a little more medially, you can see some tracheal rings. So here, sternal notch, I am going to rotate my transducer 90 degrees. And as I start to rotate my transducer, we can start to see tracheal rings come into play. Again, we can make a few adjustments here, maybe adjust the focus, adjust the depth, make sure we line up our pearls. We will continue to slide up the neck, maintaining the string of pearls. You'll notice as we slide up the neck, the cricoid cartilage comes into view. It is the largest. I always call it the mother pearl. And we will continue to scan proximally until we start seeing acoustic shadowing from the thyroid cartilage. So again, here, we are now in a longitudinal view. And if we take our pointer, we can see our tracheal rings. We can see the cricoid cartilage right here. We can see the attachment, or the inferior attachment of the cricothyroid membrane, the inferior border of the cricothyroid membrane. We can follow the cricothyroid membrane cephalad. And then here you can see the thyroid cartilage and some acoustic shadowing from that cartilage. So I know this is my superior border and this is my inferior border. Again, if I wanted to mark this in a preoperative area, I would probably use a center line. I would come and find my string of pearls. I would scan proximal. Once I got to the inferior border at the center line, I would draw a line knowing where my inferior border is. I would then continue cephalad to my superior border and then draw another line at the midline of the transducer. And having done this, having done both the TACA and the string of pearls method, we have now not only found midline, but we can also see the inferior and superior borders of the cricothyroid membrane, and really drawing an intersection there, we know where the exact middle of that cricothyroid membrane is. Gentlemen, do you have anything to add?
Yeah, that was really good. Nicolette's got some fantastic anatomy there to show us, and one of the tips and tricks that that is really helpful in terms of that string of pearls is identifying the cricoid cartilage. It's the most anterior or the highest cartilage that you see in that string of pearls, and it was very, very prominent there in Dr. Hoag's Airway. So we appreciate her being model for the scanning.
Okay. All right. So I think at this point, what we would like to do is we would like to talk a little bit about can't intubate, can't ventilate, everybody's nightmare, and how we go down that difficult airway algorithm and end up at the final stage, the cricothyrotomy. So Jeremy, you can go ahead and share your screen. We'll talk a little bit about that, and then we'll finish up with a demonstration.
Okay, so yeah, here we are. Well, let's say it's not your lucky day, but the one in a million case, the one that you hope never happens, and you're called on to do a cricothyrotomy. There are several different techniques, several different cricothyrotomy techniques. There is the needle cricothyrotomy. There is the wire-guided or stylet-induced type of cricothyrotomy, which allows you to put a little bit bigger of a tube in instead of just an angiocatheter into the airway. And then there's the surgical or bougie-assisted technique, which we talked about a little bit earlier. We're going to show you a little more information about those. So let's first start with the needle cricothyrotomy. Needle cricothyrotomy is just that, and it's using a needle to access the cricothyroid membrane. It's puncturing through that cricothyroid membrane with the needle into the airway, removing the needle and leaving the catheter in place. Now, there's a couple of things that we need to understand about the needle cricothyrotomy. Number one, it requires, if you are doing this particular cricothyrotomy, it requires a large bore catheter. So we're talking 14 gauge or bigger. And what you'll also want a catheter that allows you to put a syringe on the end of it, so a Luer lock capability, so that when you access the cricothyroid membrane and puncture through that, you'll be able to aspirate air and confirm that you're through all of the pretracheal layers. A couple of other things. Number one, angiocatheters are the most accessible large bore needles that we get to, that we can access. However, they were not meant to go into the trachea. And the reason is because those catheters, once they warm up, they soften, and they're more likely to kink and cause an obstruction. So there are specific cricothyrotomy needles that you can use to access the airway. The Cook emergency catheter is one. The Revusic needle is another. They're here in the image on the right. However, if you don't know where these needles are at, then you're likely going to go with an angiocatheter because, as I mentioned, they're the most accessible. The second thing is once you get that large bore catheter in the airway, it is, even though it's a large bore catheter, it's still a very, very small lumen. And if you're going to at least remotely be successful at ventilating, then you really do need a transtracheal jet ventilator to access the amount of pressure that's needed to get through that small catheter. So unless you know exactly where that transtracheal catheter is at and how to set it up, it could be challenging when doing a needle cricothyrotomy. So here are the steps for needle cricothyrotomy: identifying the membrane, take the needle in your dominant hand, puncturing through that cricothyroid membrane, and then angling, once you're through and you're aspirating air, angling that needle in a caudad direction, sliding the catheter over, and then removing the actual needle. Disconnect the syringe and then connect your jet ventilator. Now, one other thing is that when providing jet ventilation, you need somebody holding that catheter in the airway. That will be their sole job, because if somebody is not holding that, the very first trigger mechanism using that jet ventilator, the catheter will go flying right out. So definitely some points to consider if you are performing a needle cricothyrotomy. And just by way of practicality, if and I've looked this up, there is evidence out there. Researchers have done surveys on anesthesia providers in terms of which cricothyrotomy technique they would probably use if required to do a cricothyrotomy. Guess what? It's no surprise. They choose needle cricothyrotomy. The reason is because as anesthesia providers, we are used to using needles. We put in IVs, we do peripheral nerve blocks, we do central line A lines. So we're used to using needles. We are not used to cutting the neck or cutting any tissue with a scalpel. All right, before I move on to the surgical cricothyrotomy with my fellow presenters, anything else to add or any questions that we need to address?
Jeremy, you make a really good point in regards to the pressure that's released from the actual jet ventilator. That's, 50 PSI from the diameter index safety system for the actual anesthesia gas machine. So that amount of pressure is going to cause that catheter to totally fly out if no one is holding it. So you bring up a really good point in terms of that person's sole job is to make sure that catheter is secure and stays in place. because that's 50 psi right there.
Yeah, and that's a lot of pressure. The good news is if you've used a transtracheal jet ventilator, you can regulate the pressure. There is a pressure gauge. Typically, if you're going to be ventilating with that, you'll want to keep the pressures around 20 to 25 psi, and really just look at the patient's chest as you do a 1 second burst with the jet ventilator. Look for chest rise, and as you get that chest rise, let go of that triggering mechanism. Another important piece of this is if you're ventilating with a transtracheal jet ventilator, we should have somebody up at the top of the airway, performing a jaw thrust, but performing some means for gas to egress out and have exhalation. Otherwise, we could get ourselves into a barotrauma situation pretty rapidly. So that's a great point in terms of the pressure. Okay, well, let's talk surgical cricothyrotomy. We're really not going to talk very much about the wire-guided, the kits tonight. So this would be the Selgener technique and using the Melker cricothyrotomy kit. If you are going to perform that cricothyrotomy, practice with the kits. Get them out, get the expired kits in your hospitals, and get familiar with the equipment so you can practice with them. The technique is very similar to placing an arterial line using a wire and sliding a catheter over the top of the wire. Okay, so we talked earlier about surgical cricothyrotomy, and specifically the bougie assisted surgical cricothyrotomy. Here's what you need. Easy to find in any area of the hospital. We have a scalpel, a syringe, a 6.0 endotracheal tube, and a bougie. So now I've had some people ask me in terms of the size of the endotracheal tube. And, why do we use a 6.0? You don't want to go too small because you have to have the endotracheal tube fit over the top of the bougie. And you can get a 5.5 tube over, but it's very limiting, and the plastic on plastic can sometimes stick. A 6.0 moves over the top of the bougie very easily and is of a small enough diameter that you can place it through the cricothyroid membrane in most adult patients. In terms of the technique, identify the cricothyroid membrane, and if we've done that using our POCUS assessments and have it marked, then golden. If it's an emergency situation and we don't have rapid access to an ultrasound probe, then we would use a palpation or even a vertical incision and place our finger through that incision to identify the cricothyroid membrane. In terms of the laryngeal handshake, this is a technique where you use your non-dominant hand. You'll stand on the right side of the patient. You'll use your non-dominant hand, come over the top of the head, and start at the chin and slide your thumb and your middle finger on the side of the neck down until you feel that thyroid cartilage. That's the biggest cartilage in the larynx there. So you're going to feel that. You're going to lock your thumb and your middle finger onto that cartilage and onto that thyroid cartilage. And then using your index finger, you will palpate just below that and palpate the cricothyroid membrane. Once you've got that membrane, you can go ahead and do a horizontal stab incision. So just directly at a 90-degree angle, stab through that membrane until you've punctured through all the pretracheal layers. And you will then cut to one side of that cricothyroid membrane. The great thing about the cricoid cartilage is that the posterior and lateral sides of the cartilage provides a degree of protection. They're bigger than the anterior arch. So once you get to the side, you're going to rotate 90 degrees and cut all the way to the other side. At that point, once you have that incision, you're going to use your index finger and place that, your non-dominant hand, and place that through the incision. There's two reasons why we're using our finger to palpate inside that incision. Number one is to make sure that we have cut through all the pretracheal layers. One of the biggest reasons for failure of a cricothyrotomy is not going all the way through all those layers of tissue. And so when a tube's placed, it's placed inside that tissue and not inside the tracheal lumen. Therefore, we get subcutaneous emphysema and we're not ventilating the lungs. Another reason we put our finger in is so that we can feel on the pad of our finger the bougie stylet as it enters the trachea. We can confirm placement, and I don't always feel this when we're practicing with pig tracheas and with 3D models, but you potentially might be able to feel the bumping of the anterior portion or the distal portion of the bougie, and as it angulates and bumps across the anterior portion of the trachea of each of those tracheal rings. At that point, we're going to railroad or pass the endotracheal tube over the top of the bougie and into the trachea. We'll remove the bougie, inflate the cuff, attach either our anesthesia circuit or our bag for ventilation, and confirm placement using end-tidal CO2 monitoring. And there we have it. That's the technique as we describe it. And I'm going to go ahead and stop sharing here for a moment. This is the very first time that we're going to do a virtual cricothyrotomy. So we discussed doing this. We're going to go back to the lab with Christian and Nicolette here. And Christian, are you gonna describe the techniques, or am I gonna describe the?
You're going to walk us through it like we have never done this before.
Sorry, Jeremy.
All right, you guys, this is my very first virtual cricothyrotomy in my entire life, so I'm excited about this. Okay, all right, so we see that Nicolette has a porcine model of pig trachea here, and if you'll notice, Nicolette, you're right-hand dominant, is that correct?
I am.
Okay, perfect. So she's standing on the correct side. She's standing at the right side of the patient. That way she can use her non-dominant hand to lock in that larynx and lock in that thyroid cartilage. So there you can see that she has her thumb and her middle finger on that thyroid cartilage, and she can use her index finger to palpate the cricothyroid membrane. So we can see that perfect. Excellent.
Yeah,
all right.
Right there. Perfect.
All right, so she's filling that indentation. Now, again, if we've done POCUS and we have already marked, that's going to help us already identify where it's at. If not, and this is an emergency situation, maybe the patient has a lot of neck tissue. We can't necessarily feel the anatomy or the thyroid cartilage and the cricoid cartilage. Then we do a vertical incision first. Then put our finger in and feel for that cricothyroid membrane. Once you are sure that you're feeling the cricothyroid membrane, we're going to do a transverse incision. We're going to start with our stab incision. So go ahead, Nicolette, and anytime there's something sharp nearby, move that. We're moving that index finger out of the way.
Right. So do you want me to do a vertical or a transverse incision?
Yeah. Why don't you do a vertical first, just so that our listeners and our viewers can kind of see what that looks like. We're starting on the thyroid cartilage and doing a vertical incision. Now, of course, if we were doing this in real life, there would be skin, there would be, adipose tissue to go through as well. But that would be the vertical incision, which opens up the tissue. And then once we move the scalpel out of the way, you can see that Nicolette is kind of dissecting some of that tissue with her index finger. And she has the ability to better palpate the last thing.
Okay, I hear you now.
The anterior neck. All right, so Nicolette, how are you feeling that cricothyroid membrane pretty well?
I am. Good. Yes.
All right, excellent. Okay, now go ahead, and again, anything sharp, we're moving that index finger out of the way, and go ahead and do a stab incision at a 90-degree angle. And once you're all the way through,
like this, or 90 degree?
Perpendicular
90
to the
degree
tissue.
to what the cricoid cartilage would be
Love
at.
it.
Yep, just like that. Perfect. All right, so now you're going to go ahead and incise laterally until you meet resistance with the cricoid cartilage, with the lateral side of the cricoid cartilage.
Okay. He wants me to.
Okay.
You guys, this is a big incision. It's an emergency. We've got to get a tube in, and we're going to rely on our surgical colleagues.
Other lateral side too.
Yep. Rotate it 180 degrees,
I see.
and then cut all the way to the other side.
Loving it. Okay.
You need a big enough incision to get your finger in. So go ahead and palpate now with your index finger of your non-dominant hand. And yeah, get that scalpel out of the way. The last thing we want to do is injure ourselves or anyone else.
Ian?
Oh, yeah.
All right, now with that index finger, are you feeling
All
the
the way down the trachea.
inside of the
Yes.
cricoid cartilage?
Yes.
There you go. Excellent. So we know that we're all the way with the angulated end, and go ahead and ride that into that hole. Now, sometimes we'll keep our finger in there to help initially place that bougie. And you want to put the bougie on the pad of your finger. So flip it around so it's going in on the pad of your finger.
Like this?
Yep. There you go. Nope.
Yes.
Flip it up
You're
to the
going
pad
up,
of your
you're going
finger,
the
not
other
your
way.
fingernail, the other side.
Oh, sure. I love I love it. All right.
There
So
you
like
go. Yep, just
this,
like that.
Jeremy. Yeah, I
Yep,
gotcha.
like that. There
Although-
you go. Now that
Doesn't
helps
wanna go.
facilitate the movement of the bougie into the trachea. And there you go. You can angulate the bougie and kind of rotate it
can
It's
see it.
towards
coming.
the patient's
Just
face.
keep pushing. You're fine.
Yep.
Just keep pushing. I don't know.
Now there have been case studies
Keep
that
pushing.
if
I'm
we
on
do
something.
too much force with the bougie,
Yeah.
you can create. Yeah, you can place the bougie in the tissue, especially in the posterior part of that trachea. The great
Yeah.
news is with these porcine
Yeah.
models, you can kind of look up and see where that bougie
Yeah.
is.
Huh? I know I'm cheating. Don't you love it? I don't know why it's not all the way through. All right, Jeremy. So this is one of those times I think I
Okay,
didn't.
good. So we're running into a little trouble here.
Yeah.
Sometimes we're
Love
not
it.
all the way through. So make sure that you have incised all the way through those pretracheal layers, especially with these porcine models. When we practice this technique, we've practiced it in the past at the AANA conference. We've practiced it at other state conferences, and participants have not cut
didn't
all
get
the way
more.
through, which is a great
I
learning
think it's all the way through.
piece of
I
learning.
mean, I think I'm on
Now,
something.
you're
I'm
getting
hitting
you're getting your finger all the way in there. That bougie's got to
Yeah.
fit.
I know. I think I'm hitting something. There
There
we
you
go.
I can see it sliding now.
Yeah.
I'm not sure that there may have been another like a really thin piece of tissue that we weren't all the way through, because that
Yes.
bougie absolutely went in a lot easier that time.
Yes,
And
it did.
we've definitely dilated that opening. So as I mentioned
All
earlier,
right.
we're going to rely on our surgical colleagues to help us out once
All
we've
right.
saved the patient's life here in this
Once we save the
emergency
patient.
situation.
All right.
Okay, so we're railroading. We're passing the endotracheal tube over the bougie. Remove the bougie. Now another thing is we're lower in the airway, so we don't have to go too far. Once you see that cuff disappear through the incision, you don't have to go too much farther. It's about 10, 12 centimeters of depth. So once you see that cuff disappear, then you're going to stop, because you don't want to main stem intubate the patient.
Awesome. So that's at 10.
So, yep, there you go.
All
Perfect.
right.
We don't see the cuff at all. We're going to inflate the cuff, and then
I
we're
don't have a
going
syringe,
to
but we'll
connect it
pretend.
to our ventilation device.
There you go. All right, Jeremy. Did it.
So Jeremy,
we
in
definitely
your
saved that
experience,
pig trachea.
yes.
I don't know if we saved
But
it.
Jeremy, in your experience, I'm not sure if you've done this on a cadaveric model or not.
Yeah.
How thick? Because I feel like, when we use a 3D printed model where we're using like maybe a piece of like metal tape as our cricothyroid membrane, it's always like a quick puncture and you just feel like you're through. But it's obvious, again, with the pig model, I think the cricothyroid membrane is probably a little different. But in a human model, I'm just curious if you've ever experienced maybe not being deep enough or not appreciating how thick it would be.
Yes, absolutely. So when using 3D printed models and simulation models, those are good in teaching the technique and the steps. And they give you a sense of what to do and the order to do it, and a little bit of the feel. However, in human tissue, and certainly in these porcine models, the membrane is thicker. And the number one cause of failure in the surgical technique is not puncturing through all the layers of tissue and having a false passage of the tube into a pretracheal layer of tissue where we just are ventilating in that and causing essentially subcutaneous emphysema. We're not in the trachea. So it does require some attention, and the membrane is a bit thicker when you're using the surgical technique on actual tissue.
Okay, and just to clarify, you do like the vertical incision first, just to get down to the membrane itself.
I like the vertical incision if I have not already identified exactly the spot I'm going to go, and if I'm having any trouble identifying the cricothyroid membrane. Now, if you
Okay.
read the emergency medicine literature, there's plenty of literature on cricothyrotomy for emergency medicine physicians, and they do advocate for that initial vertical incision because a lot of times they are doing this in very high stress situations, emergency situations, and it does allow you, once you do that vertical incision, it does allow you to feel that cricothyrotomy or cricothyroid membrane a lot better.
Okay, but for the actual puncture of the cricothyroid membrane itself, it's a transverse incision, correct?
Yes. Once you,
Perfect.
again, once you know where that membrane is located, it is now a transverse incision. You want an incision big enough that you can get your finger into that incision.
Okay, I think at this time we could take some questions. I'm not sure if we have any questions in the
chat.
in the chat.
I did
but-
see someone's hand up earlier, and I know Mark's been answering questions in the